Good morning, ladies and gentlemen, and we are continuing on with our ophthalmology lecture video sessions. Today we will be talking about retinoblastoma, which is our second differential in the theme of ocular deviations. We are putting retinoblastoma here because a very common presentation of retinoblastoma is ocular deviation. In fact, so much so that every child that presents to you either as a family physician or as an ophthalmologist must have his or her fundus examined. Why do I say family physician? Well, you seeing a child who has an ocular deviation, either yourself do a fundus evaluation if you have an ophthalmoscope, and I'm sure you're confident in doing it, or send or refer that patient to an ophthalmologist for an ophthalmoscopic or fundus examination. If you don't have an ophthalmoscope, you should have an ophthalmoscope, by the way, because you need to ensure that the deviation that the child is presenting with is not because of a retinoblastoma. That is really essential. Retinoblastoma is associated with a lot of mortality if not picked up in time, not picked up early, because it metastasizes and has the potential to kill. It's a very devastating disease for the parents. It's also devastating for the child because if the tumor is picked up and it's large, the eye might need to come out. And later in life, this child might need to be counseled in order to tell him or her why it was necessary to do it, because he could have this enucleation could have its own issues with the child, his psychological issues, psychiatric issues that need to be dealt with appropriately, because we are not dealing with non-living entities. We are dealing with human beings, and we need to care about them as human beings. We shouldn't look at them as diseases, which is really important. This is what we will be talking about today. We'll start off with definition, epidemiology, genetics, move on to presentation, then differentials, and then finally management and outcomes. Differentials is really important here. We'll spend a little bit of time talking about differentials. That's why it's a separate heading in our to-do list. We'll start off by talking about definition, epidemiology, and genetics. So retinoblastoma is a primary malignant tumor of the retina that arises out of immature retinal cells, the retinoblasts, that affects infants and children. This is the most common intra-ocular malignancy of the childhood. Most of the tumors are diagnosed by 5 years of age. It is very rare for this disease to be diagnosed after 10 years, simply because the child has either passed away or the disease was diagnosed before and some form of management had saved the child's life. It has no gender or racial preference. It affects everyone, males, females, and people of all races and ethnicity. The incidence of this disease is highest after birth. The median age of diagnosis is 1 year for bilateral tumors and 2 years for unilateral disease. Unilateral disease is sporadic and is also usually unifocal. You usually have one mass or one focus of the tumor in the retina. 70% of the tumors are unifocal, 30% are bilateral. Those bilateral tumors are also multifocal, so you have multiple foci of tumors within the retina. Unilateral are sporadic, as I've just said, and bilaterals are usually hereditary and follow an autosomal dominant pattern of inheritance. As I said, this disease has I haven't said it yet. This disease has the propensity to metastasize, and it metastasizes to the central nervous system and to the body through the various routes. It goes to the central nervous system, to the optic nerve, and it can also sort of metastasize widely through hematogenous spread. It can also involve or locally invade by passing outwards from the sclera. Untreated, as I said, it can kill the patients within 4 years of the onset of symptoms of the disease. So why does this tumor occur? The genetics of the disease, it is because of loss of both alleles of the retinoblastoma gene. This is a tumor suppressor gene, and you need to lose both copies of the gene, i.e. both copies of the gene must be mutated to cause the malignancy. There are two patterns, as I said, sporadic and inherited, and if the first mutation occurs before the first mitotic division of embryogenesis, then you get a hereditable disease. Hereditable disease, as I said, are usually bilateral. They can also be trilateral, which is involvement of both eyes plus the pineal gland, and tend to be multifocal. If the mutation occurred somatic cells after fertilization of the egg, then you get a non-heritable sporadic form of a disease, which are usually unilateral unifocal tumors. We'll talk about disease presentation now, and as I've already mentioned, unilateral tumors are much more common as compared to bilateral. Unilateral 70%, bilateral 30%. So the presentation is going to be mostly unilateral, but it can be bilateral, and the most common presenting feature is leukocoria or white pupillary reflex. And to the parents, it appears that there is a difference between the color of the two eyes, and since the most common cause that the general population knows of a difference in color is cataract, most parents or guardians of the child, because the child is usually too young to explain him or herself what's going on, they come in thinking that the child has a cataract. That is why the differential is so important, and we'll get to that in a bit. And this tumor appears white because of the reflection it produces. This tumor usually has a lot of calcium in it, which produces that white reflex. The second most common presentation is deviation of eyes, as I've already talked about. And this deviation is because of poor vision, and that poor vision is obviously because of the tumor. The deviation could be eso or exotropia. What is esotropia? Exotropia, we'll talk about it when we talk about strabismus, which is the last of the differentials in our theme, in fact, which is the last topic of your clerkship. Thus, every child who presents to you with a deviation must have his or her fundus examined to ensure that this is not the cause of deviation. Other features of the disease would include watering. That's because of poor vision and the child rubbing his eyes. That can also be because of the other presenting feature could also be pain and redness, and that is because of a rise in pressure of the eye. That is because the tumor is now blocking the drainage channel, the anterior chamber angle at the trabecular meshwork. The fundus examination of these children usually reveal either a unifocal tumor mass, which is a feature of unilateral disease, or multifocal or multiple foci of tumors, which is a feature of a bilateral disease. Together with this, you might also see some cells in the vitreous. The reasons that these tumors or these masses appear white when doing a fundus examination is because they have a lot of calcium in them. So when you're doing a ophthalmoscopy, you see a single large white mass indicative of a unifocal unilateral disease. But again, it's not necessary that it's only a unilateral disease that would have a unifocal mass. You could have bilateral diseases with unifocal mass. It's just that if you have a bilateral disease, the chances of getting a multifocal tumor are greater. The metastasis and extension is something that's unfortunately associated with this type of malignancy, and it can extend to the brain through the optic nerve. It can also spread to the body hematogenously, and it can also locally invade by becoming extrascleral. Remember, it's a tumor of the retina. It invades the sclera and then goes out of the eyeball, which is a form of a local spread or a direct extension. The diagnosis is usually visual, as I'll just show you fundus examination as well as the appearance of a child. But you can do a CT scan, B scan to see the tumor if doubt exists, and they appear as highly sonoreflective or echogenic mass, sonoreflective / echogenic if you're doing a B scan, or highly reflective masses on CT scan because of the calcium content. However, do note that the calcium content would vary, so not all of the tumors might appear as highly reflective on CT scan or B scan. For metastasis, an MRI is usually indicated. So this is leukocoria. The right eye appears normal. The left eye has the characteristic white reflex that I keep talking about, and that is because of the calcium content of this tumor, which produces this characteristic white reflex. This is a large fungating mass, and unfortunately it's destroyed all features of an eyeball to be more precise. In fact, this tumor is growing so rapidly that it's killing itself. As you can see, the interior part of the tumor is all necrotic. This is highly unfortunate, but this is what happens when parents would not agree to a treatment, because treatment involves in removing an eye, which is very difficult a decision for a parent for their child. I mean, imagine what would go through their mind when you tell them that we need to remove the eye to save the life. They would rather jump to any possibility where the life of the child could be saved. Those could be religious healing, faith healing, hikmat, homeopathy, anything, and they honestly would cling to any hope. And if you reject other forms of medicine, alternate medicine, these parents and these patients would probably never come back to you, because you are rejecting a very strong belief that they might have. So the thing that we tell them to do, look, you want to do anything, you're free to do it as long as that does not endanger the child's life. You want to try uh, religious therapy, it's fine as long as they don't do any interventional stuff that might damage the child. And that is true for other alternate medicines. You just need to tell them, look, we do not, as doctors, we do not want to discourage you from other forms of healing that you might have in mind, but do remember that delaying this procedure, i.e. removal of the eye, could mean that your child's life is sort of under more danger, or the chances of your child losing his or her life are increasing because we are wasting time. But obviously you can't force them, and outrightly rejecting them, no, you can't do anything else, would probably mean that they would never come back to you or to another doctor, and they would continually go to various faith healers or other forms of healing, because they would sort of tell them that, yeah, we can save the child's eye, which is probably incorrect, because most of the time this tumor does not sort of deactivate itself. Deactivated retinoblastomas are called retinocytomas, but they are very, very rare. Most of the time they do kill. In fact, the majority of the time, if you don't do appropriate intervention at the appropriate time, it would kill the child. The fundus examination of these children would either show something as depicted on the left, i.e. a solitary mass, a unifocal tumor, which is a characteristic of a unilateral disease. It's a large white mass because of the calcium that these tumors have in them. The pictures on the right represent multifocal tumors, which is a characteristic of a bilateral disease. So you can see left and right eyes with multiple foci, multiple white masses, indicating multiple retinoblastomas, or multiple foci of retinoblastomas in both eyes. This is B scan on the left, and on the right a CT scan. The B scan shows a highly reflective mass, which is characteristic of most retinoblastomas. On the right, we have bilateral retinoblastoma. Again, you can see highly reflective masses in the eyes. Do remember that not all tumors would have such a level of intralesional calcium so as to produce reflectivity as indicated by these images. If you'd like to know more about B-scan, we have an entire video resource on them, so be sure to check it out. Now we are moving on to differentials, and differentials is rather important because breaking a news to a family or parents or guardians that their child might have a tumor within the eye, which is malignant, is something that needs to be done very cautiously and with a lot of confidence, especially if you are a family physician who is diagnosing this disease. And family physicians can do it if they have an ophthalmoscope and they are confident enough to do dilated fundus ophthalmoscopy. What you are basically looking for are those masses together with the leukocoria or the history, as we have seen, especially if there's a family history, that would sort of raise your suspicion even more, because remember, bilateral disease can have is a hereditary disease and tends to run in families. So when you have decided this is a retinoblastoma, you need to be sure. So we need to know the various differentials that can produce the telltale leukocoria or the white pupillary reflex that you see. And we need to be sure that we are telling the parents the right thing. Even if you are just suspicious of it, you would tell the parents, look, I suspect this, go to an ophthalmologist for a definitive diagnosis and a management plan. Your responsibility as family physician is to break this news in a manner that the parents or the guardians can digest it and can reflect on it when they go see an ophthalmologist. So your responsibility is to be sure that, or be very, very suspicious that, yeah, this is a tumor I'm looking at and not something benign like a cataract. Because remember, white pupillary reflex is also produced by a cataract when you do a torch examination. Thus, differentials here are sort of important. This is a list of differential diagnoses of a white pupillary reflex, leukocoria. Cataracts we've already talked about. Just remember that on an ophthalmoscope, cataracts appear black. It's on a torch examination, they appear white. We'll talk about persistent fetal vasculature, coarse disease, and retinopathy of prematurity in a bit. We've already talked about retinal detachment, and because of the accumulation of fluid, subretinal fluid through the break, that actually causes a detachment. That fluid prevents the choroidal red reflex that you see on an ophthalmoscope, thus producing a leukochoria or white pupillary reflex. This is what persistent fetal vasculature is, and as the name suggests, persistent fetal vasculature implies that the fetal vasculature persists once the baby is born. In normal development, fetal vasculature regresses, so in 95%, most of the time you don't see this, but if you have a preterm baby, 95% of preterm babies would show some level of persistent fetal vasculature, and even some full-term infants would show persistent fetal vasculature as well. The extent of vasculature that you see would depend upon the severity of the disease, and this is basically the vasculature that supplies the growing lens and the other parts of the eye, and they tend to persist after birth. It's a unilateral disease, it's a very sporadic disease, and it is the second most common cause of a white pupillary reflex, as can be shown on the first picture. In this case, it's the left eye that's involved. The right eye shows a normal red reflex of an ophthalmoscope that you see during ophthalmoscopy. The second picture actually shows you a little stalk, and this stalk is representative of this structure as seen from histology, which is the stalk or the hyaloid canal that carries the hyaloid artery for development of the lens and some other structures. But it is supposed to regress once close to birth or once the baby is born. If it persists, it's called persistent fetal vasculature, and it can sort of interfere with vision depending upon how much of the tissue is left behind. And the presentation again is a white pupillary reflex with poor vision. The level of poor vision is going to be dependent upon, again, the number of the disease severity and the age at which the child presents. Obviously, the older the child, the greater the severity, the more the visual loss because of amblyopia. Management is obviously removal of this tissue if it's significant enough to cause visual loss, which is done by vitrectomy. Moving on to Coats disease. Coats disease is a disease whose etiology remains yet to be understood. It affects mostly males. About 8 years of age is the mean age of presentation, and it's largely a unilateral disease. The presentation is, of course, going to be with leukochoria, white pupillary reflex, together with some form of visual loss, depending upon the severity of the disease. And what you see in this disease are various types of vascular malformations. You see telangiectatic vessels, which are like these small spider vessels, large dilatation of vessels, as can be seen here, and this blue arrow shows a macroaneurysm or a large aneurysm. And these large aneurysms can leak profusely, as shown in the middle picture. You have a lot of exudation here. And when you do an FFA, these aneurysms appear as light bulbs, like this, large light bulbs. Remember, diabetic retinopathy, you had microaneurysms, which are small, producing small light bulbs. These are macroaneurysms producing larger light bulbs. If it is a very localized disease, just telangiectatic vessels without much leakage, not affecting vision, it's usually observation. But if there are larger macroaneurysms which leak, then you obviously need to do some form of photocoagulation to seal these before they cause some form of loss of vision. Moving on to the next differential of leukochoria is retinopathy of prematurity. Retinopathy of prematurity, as the name suggests, is a disease of a preterm birth, and that is due to a mismatch between the amount of oxygen that the retina requires and the amount of oxygen that the baby is being provided with. So it's a relative difference or a relative mismatch between the two, and that produces retinopathy of prematurity. The pathology is that when, as a fetus, the fetus is under a sort of a hypoxic state of development as compared to after birth. So if you have a preterm baby and that baby is given unmonitored oxygen, supplemental oxygen, that supplemental oxygen can actually be toxic to the developing retinal vasculature, because the retina is not expecting that amount of oxygen coming in, and that can cause oxidative damage to retinal capillaries, which would then start leaking. And obviously, because you have a preterm baby, not all of the retina is vascularized. Some of the retina is non-vascular. And this disease, as I'll show you some pictures, usually starts off as a clear demarcation between a vascularized retina and an avascular retina. And over time, on that margin or on that ridge or the line which divides the two retina, you have various types of problems developing. And all those problems are because of damage to retinal capillaries at that growing zone, which are getting damaged. And they're getting damaged because they're getting too much oxygen, and they're not used to that amount of oxygen because they're expecting less amount of oxygen because it's a preterm baby. It's supposed to be inside the mother's womb and developing. So this disease is because of high supplemental oxygen. Any level of supplemental oxygen, really high relative to the retinal requirement. So what actually starts happening is that obviously you're going to have a baby who's going to have poor vision and white pupillary reflex or leukocoria. The features that you see in the retina, as I talked to you about, is first a line which demarcates vascularized from non-vascularized retina. Then, because of capillary damage and ensuing retinal ischemia, you get new vascularization because of release of VEGF along that line. And this new vascularization can actually leak blood, produce hemorrhages, which would then produce fibrous bands between the retina and the vitreous, because these new vessels tend to grow into the vitreous, and they can actually pull the retina, causing retinal detachment. This is a devastating disease in the sense that it can cause a lot of loss of vision, in fact, even blindness. So you need to appropriately do laser photocoagulation even to that premature baby at a very young age in order to, sort of get rid of the ischemic stimulus. There is mounting evidence that anti-VEGF would also work, but since this is a baby, we need to be very sure that this treatment is efficacious to the general population, for the general population, before it can be, sort of used on a larger scale. So let's look at the retina. So this is the ridge I keep talking about. This is the normal vascularized retina. This is the avascular retina. You can clearly see the difference between the two. And this is the line or the ridge that divides the two. Along this line or ridge, you would have developing capillaries that are getting damaged, and they're getting damaged because of that high level of oxygen that they're receiving. Again, this high is relatively high to the retinal requirement at that time, and this is associated with getting supplemental oxygen, and that supplemental oxygen needs to be really carefully monitored. So the disease happens when you have unmonitored supplemental oxygen, which is going into the retina, which is high for this particular developing retina in that baby. Later on in the disease, along that same line or ridge, obviously this is a different eye. You have new vessels, which are shown by these white arrows, and they produce hemorrhages, which is shown by this black arrow, and these can eventually lead to a retinal detachment. Finally, we're talking about management and outcomes. We have done the differential presentation and definition, epidemiology, and genetics. We spent a little bit of time on differentials because we need to be sure that what we are looking at is really a retinoblastoma. So the aim of the treatment is preserve life first. Remember, this can metastasize, spread everywhere in the body, and kill the child. Then to try and preserve the eyeball itself, and then finally to preserve vision. So these are our priorities: life, eye, and then vision. I've already touched upon this aspect before, that you need to be very careful as to how you explain this to the parents, because you need to tell them that the life is in danger and that the eye might have to come out. You need to communicate it effectively and sensitively, ensuring that any alternate forms of treatment that the parents might have in their mind, like faith healing, are not outrightly rejected. Faith healing is something that's very central to this region, and it's something that must be respected. You express your concern that this is putting the child's life in danger, and any delay in this might prove to be detrimental. But do not outrightly reject other forms. You said, you let us do our thing, you do your thing, and so that they keep coming back to you, because if you outrightly reject it, they might just get discouraged and not seek professional medical assistance altogether. Once the child is old enough, he would need to be counseled as to what happened to him, why it happened to him, so that the stigma or the trauma that he might face is sort of tempered or dealt with appropriately. So what are the management options that we have? Well, depending upon the size of the tumor and the laterality of the tumor, we can do chemotherapy. Chemotherapy is usually between carboplatin, etoposide, and vincristine. Again, it's not the ophthalmologist doing it, it's the oncologist doing it, and a pediatric oncologist, to be more precise. For bilateral tumors, this is the primary therapy. You cannot obviously take both eyes out. Unilateral tumors with salvageable vision, you have a focus that's away from the fovea or the macula that hasn't really destroyed the central retina, you might want to try chemotherapy. Enucleation, i.e. removal of the eye, is for unilateral large tumors with questionable visual prognosis in the long run, together with dangers to the child's life. For bilateral tumors, it is only indicated if it's life-threatening, because you don't want the child to lose both his eyes. That's the biggest trauma, not only for the child later on, but for the parents as well. And obviously, when you take the enucleation, it's always at the frozen section. We have had a video on frozen section. You can go and see that again. We talked about it when we were talking about ocular surface anomalies. And if you do have cut cells if you have tumor cells in the cut end of the optic nerve, you send the patient immediately for chemotherapy because the tumor has a very high chance of recurring and spreading everywhere. It was probably already spread out, but recurring is more of a question, more of a danger now. Metastasis is usually fatal, and you can try high dose chemotherapy as palliative, but it usually kills the child. So this is a child with enucleation. We have already talked about enucleation before. We have already talked about frozen section. You can go back and refer to trauma or ocular surface anomaly discussion for both of these things. Again, some pictures showing how enucleation is done. Post-enucleation in prosthetic eye can be implanted. We've already talked about prosthetic eyes. Again, we were talking about ocular trauma, and these prosthetic eyes can be customized to match the fellow eye, which is really important for cosmetic appearance. Finally, we are going to talk about outcome, and recurrence is a real possibility, either because the frozen section was done wrong, or when the enucleation was done, a long enough section of the optic nerve wasn't cut, which would increase the chance of the part of the optic nerve left behind after enucleation to actually contain the tumor cells. And sometimes, in spite of your best efforts, recurrence would happen. Managing recurrence is basically doing an MRI first to ensure that it is only here that the tumor has recurred and there are no metastases, and you can try debulking the tumor or trying high-dose chemotherapy. But the actual chemotherapy is again dependent upon the pediatric oncologist. Hereditary form of retinoblastoma basically precludes those patients developing other form of tumors in spite of a successful management of the retinoblastoma itself. This is a recurrent tumor of the right eye, and it can be because of the reasons that we've already specified. Thank you very much for your time and attention. If you have any questions, you know where to ask.